Much for coming to the joint ISMRM and WFPI virtual meeting on pediatric MRI head and neck protocols. My name is Muriel Bruchhage. I'm an associate professor here at the University in Stavanger with unusual great weather, as you can maybe see in the reflection here. We've been showing off to the people joining us from the UK. And I will be moderating on behalf of the ISMRM together with Fabricio on behalf of the WFPI. In case you want to introduce yourself shortly.
Yes, thank you. Yes, it is an honor for me to be moderating this session. And I would like to express my gratitude to the International Society of Magnetic Resonance in Medicine and to the World Federation of Pediatric Imaging and Camilo for the kind invitation opportunity to moderate this important section. My name is Fabricio Goncalves. I'm a pediatric neuroradiologist at the Children's Hospital of Alabama, and I am a professor at the University of Alabama in Birmingham. Thank you very much.
All right, I will go shortly before we introduce the fantastic speakers. I obviously completely agree with Fabricio. What an honor to be here and to be invited to moderate this very important session. Some house rules. All of the microphones should be off besides the speakers. You can ask any questions, but please do it in the chat. Me and Fabricio will be looking through them and take vigorous notes so that we can get back to it later at a point during Q&A. And all of these sessions, or the session is recorded and will later be uploaded to both the WFPI and the ISMRM websites. Should I go with a very short introduction, or do you want to do it?
Well, I would like to first start with Felice because he's a good friend. I know Felice for more than maybe 12 years, 15, almost 15 years now. And, you know, Felice is a super nice human being, super cool. And Felice is highly, you know, apart from the accolades and personal qualities, he's a respected pediatric neuroradiologist with extensive experience in head and neck imaging. Felice is currently serving as a consultant at Gosh in London, UK, where he works mainly with head and neck imaging and neuroradiology. Felice has contributed significantly to the advancement of pediatric imaging through research and clinical practice, and we are privileged to have him share his insights with us today. And I was asking yesterday, Felice, do you have any accolades? Do you have any degrees, any awards that you have recently that I don't know? And he said, "Oh, please say that I'm the coolest dad in the neighborhood." So I agree. I will not share his picture because he didn't authorize me. But yes, I think Felice is also a very good dad. Please, Felice.
Thank you for the very kind introduction, and it's nice to see you all. I need to be made host to share the screen, I think. If the host can make me host. Is there anybody from the, I think it's the WFPI. Anyway, in the meantime, I would like to introduce this lecture that will be rather conceptual lection in a way, and I will try to. When we see as pediatric neurologists, we say so many wrong, especially for the head and neck, but not only, protocols that comes to us from other hospitals, and it makes so difficult the management of the patient. So I will just show you some concept of why head and neck is different and why pediatric radiology that includes head and neck, neuro, and body is different, and why, let's say, a child is not just a small adult. Let's see if I can share the share button. No, I think...
Or WFPI host to make you host. Let's see if she
Yeah,
can.
because I have the share screen button, but if you try to share, it says the host disabled participant screen sharing. That what it was what they told me before. So I just try just need to...
Hi guys, sorry, let me try.
Yep. Okay, now it's now
All
I'm
right,
the
there we are.
Cool. Okay. Yes. So I think you can see now the my presentation. So yeah, I will present this this paper, a white paper that we wrote 1.5 years ago on standardized MRI protocols. Just in general, if you are interested on basic pediatric neuroradiology lecture, I have put all the lecture that we recorded, not only me, also some colleagues during COVID, and we keep recording on my YouTube channel. This is also there. So if you want, just check it out. We'll try just to spread free knowledge in a way as far as we can. So I would like to start with this typical Monday morning in the reporting room. You have this girl, 15-year-old, known at gosh, long time, but because she doesn't live in London, she has follow-up for her Ewing sarcoma every few months. Okay, and some of the follow-up are at GOSH, some other are done outside. So we had this scan here, and this was clearly a brain MRI, despite this is a skull-based sarcoma with a static residuum. And this was the scan that we did in November, so 2 months down the line. She had some pain, so they did a short follow-up. But the interesting thing is the difference between the brain MRI and the face MRI. And as you can see, because here there are fat-saturated images, the appearances are slightly different. Of course, you can delineate a bit better the tumor, but the extension of the tumor looks similar on axial, looks smaller on coronal, and we have this situation every time, especially when it comes to skull base, neck, petrous bone areas that are involved. So this is the typical radiology report conclusion will be allowing for the technical difference between the scan that we like very much, no convincing changes noted. But then this is the typical expression of clinician reading it because they don't know what to do with these inconclusive reports. So we ask ourselves, reflecting, this is I love paintings, and you know there is this wonder above the sea of fog that is a standardized protocol in radiology. I think we have so much interest and push toward artificial intelligence, very advanced techniques and so on, that we forget that it's very, very difficult to have across the world a standardized protocol. So how should a perfect MRI protocol look like? Standardized as much as possible and needs to be efficient. So disease specific. We know, for instance, from the pediatric neuro-oncology papers, RAPNO papers, that there are differences in scanning ependymoma versus medulloblastoma. The characteristics of the tumor are different, so the characteristics of the metastasis will be different. We need some slight different protocol for better assessing these children. However, despite efficient, needs to be easily reproducible. Sometimes these children are scanned in small district general hospital, not only in tertiary centers, and flexible because, of course, every patient is a bit different and every scanner is not the same. Most importantly, you need expert to write these protocols. And I have to say that some of these statements may look like contradictory to each other, and this is right, it's very difficult to find a balance. So we wrote this thing, these guidelines, and I have to say I'm the first name here, but I don't deserve it because I learned a lot from people that are expert in the different paragraphs that we did. And this was endorsed by several society, European Society of Neuroradiology, Head and Neck Radiology, European Society of Pediatric Radiology, the ERIC group, that is the European Retinoblastoma Imaging Consortium, and so on. And I would like to show you some example on how we wrote these guidelines and what is the rationale that you can use when deciding what protocol to give to your radiographer or techs in your institution. So we started with some basic rules. There is something very important in the skull base and head and neck region, and this is fat. So fat can be your friend or your enemy, depending on how you scan the patient. And we need the fat a lot to understand the limit of the lesion. So when scanning something in the face, in the skull base, in the neck, or in the scalp, we need T2 sequences that are with fat saturation, so stir, because most of the lesion will be hyper intense and we don't want the fat to confuse us. And also we want the fat to help us in T1. So the T1 pre will be most of the time, I will show you some exception, that will show the flexibility we want to apply. But most of the time, we do the T1 pre without fat saturation. Why? Because the fat will be a passive contrast around the lesion that most of the time will be hypo-intense. And then we will give contrast. So remember, it's very important to give contrast when you see a mass in the head and neck region, because it will help you in the differential diagnosis. And you see that we did a fat sat post-contrast in this case, because you don't want the hyperintensity of the fat to fool you. And you will you will see in this case heterogeneous contrast that is typical of a venous malformation. So let me start with this case about the importance of fat. This is a fetal scan with a large cystic lesion. Look at the proptosis. This is 27 weeks, was done at UCLH, which is the hospital that collaborate with us because they have a big prenatal and perinatal unit, and then they send the cases to Gosh when needed. And they scan this, Dr. Kelly Pegoretti, and they showed this large cyst. It can be a congenital cyst, but the main working diagnosis was possible lymphatic malformation. That is mainly cystic, can have blood. We don't expect fat in it. And this is just to show you how big was the lesion. And so an operation was planned, and the management is critical in this case. Then they repeat a few weeks down the line, the scan, and the mass is still mainly cystic, but look, it's changed. Now there are some solid or pseudo-solid areas here. The cyst is still there, it becomes a bit loculated. Again, they thought the main differential diagnosis will be a lymphatic malformation. This is probably a bit of blood because they tend to bleed. Lymphatic malformation will need a mix of sclerotherapy and sometimes operation, but if it's something else, like a teratoma, for instance, we will expect fat, we will need to demonstrate fat, and this will need different management, surgery, sometimes chemotherapy, and so on. So what is going on here? They repeated a neonatal scan, and they didn't give contrast, but they did this TIR, so fat saturated sequence that well delineated the cystic fluid appearance of the mass, that is becoming slowly more solid. But this area is hyper intense in T1. Now, because they didn't give contrast, because they are like scared of giving contrast sometimes in the neonate, we didn't do a post, fat sat post. We are not sure what was this area. Is this fat or is this blood? Because if it's fat, this will be a teratoma. If it's blood, it can still be lymphatic malformation. So what I did, I repeated the scan, and look at this also shows how different is a child, how fast can things change in a child in terms of appearances. 8 days down the line is much more solid, still cystic appearance. This area is hyperintense, hypointense in T2, hyperintense in T1. And then I ran an extra sequence, an optional sequence that is a pre-T1 fat saturated that showed that the signal was gone. So this is fat enhancing lesion. So even though this was a very weird appearances, if you keep your radiological reasoning sound and disciplined, you can describe this mass as a solidocystic mass with fat content, which is indeed the definition of a teratoma. So when you say a congenital mixed solidocystic mass with fat content, think of teratoma. The only problem is that they don't always look like that. And this is, again, an emergency. There is a compression of the airways and so on. But remember, this is the radiological definition of teratoma, just to show how fat can be your friend. And this is another example. I will not dwell too much in the orbit protocols, but just to show you orbit T1, the fats around this sarcoma here, and the post-contrast sequence is fat saturated, so the enhancing muscle, which is neoplastic, stands out around the suppressed fat. This is our proposed orbital protocol, but again, we added some optional sequences. Why they are optional? Because we cannot cook the child for 2 hours under the scan every time. We have a busy environment. We need to keep short the scans to avoid the very expensive long scan, but we have to have the flexibility to add some sequences. And for instance, MRA time of flight, so MRI angiography can be helpful, like in this case, where we have a lot of vessels, but very few high flow vessels, non-nidus. This is not an AVM. There is also a mass-like lesion. This is a congenital hemangioma. Also, there is no shunt in this in the sagittal sinus, which we would expect for such a large AVM. So these are all characteristic that of an hemangioma that does not need treatment or a bit of propranolol, but for sure does not need an aggressive treatment like an AVM. Okay, so remember, flexibility means the fact that you can have in specific clinical query optional sequences. The second important thing, very, very important, is DWI. DWI is very, very important for the brain. We use DWI as pediatric neuroradiologists for differential diagnosis in tumors, for instance, critical. And one of the world experts, Susan Loughlin, was one of my mentors in Toronto, published a lot on that. But it doesn't like very much DWI, the skull base, and even the neck. Why? Because there is air, there is bone, there is soft tissue. We need to use DWI, but we need to make it right. So you need to use either multi-shot, like the Resolve DWI, which are epi multi-shot, or non-epi DWI, because the epi single-shot sequence is very distorted. Sometimes you can use the one that you have in the brain to scan, for instance, the skull, if you have a neuroblastoma or something like that, and maybe it's still acceptable, not ideal, but not for the temporal bone. So if you have a problem in the temporal bone, you need either a multi-shot or a non-epi DWI. And this is an example. Look at the skull base osteomyelitis, an area here not enhancing, and this was restricting. This is an abscess. It needs immediately to be flagged to the ENT because they may want to operate. And this child had also Grady-Nigo syndrome. So you need to tell them if there is an abscess or not. If you have all distorted multi-shot DWI. Even more importantly, in cholesteatoma, a non-epi DWI was actually the best sequence to pick up this restriction here that is pathognomonic of cholesteatoma. And the cholesteatoma can with the CT and give also a very good spatial resolution, not only the sensitivity to the ENT surgeon. The rule number 3 is that the child is not a little adult. What does it mean? That we have specific diseases that apply only to children, and we need to act consequently, and we need to have specific disease-specific protocol as much as possible, maintaining the standardization and the flexibility I was speaking about. Look at this case. This is a mass in the temporal bone. I took this from literature because you can see here that the T1 post-GAD was done without fat saturation. And you cannot distinguish very well where the mass starts and when the mass ends. They did also a CT, and you can see very lytic appearance. So you have an aggressive mass. Now I'm telling you, this is a typical location of Langerhans cell histiocytosis. And this CT is typical appearance in Langerhans cell histiocytosis. But Langerhans cell histiocytosis present in different locations. There are a lot, but they are quite specific for LCH. And you need to scan all of them because this is the way to assess completely the patient and to give the baseline. You have skull and skull base. You have soft tissue around the skull base as well. You have vertebral bodies, typical vertebral plana. You have involvement of the brain, and you have involvement of the pituitary region. So first of all, remember, this is an MRI paper based, but you also have the complementary role of CT for bone. Hopefully in the future, we will use the black bone sequences, but at the moment, a low-dose CT is the best to check out the characteristic of the bone, and this is critical sometimes for your differential diagnosis. So remember that, but also remember the many phases of LCH as the first example of why a child is not a little adult. So you can have intracranial extracerebral masses, so you need to scan the brain. You can have diabetes insipidus. You need to look at the pituitary region. You can also have stalk thickening and so on. You can have neurodegenerative changes by way of hyperintensity in the posterior fossa, so a flare would be very good. So how we scan the brain, the spine, the pituitary, the skull base, the pituitary region, the skull base, without keeping the child in the scan 3 hours every time? Well, we try to compromise. We try to add some optional sequences when you are not sure, and we try to justify why. But as a general rule, you need, for instance, fat-saturated sequences on the brain, because like that you can see the extension of the lesion in the skull, and this applies also to neuroblastoma metastasis. So don't do a normal 3D of the brain post-contrast. Your flare will be already post-contrast, kind of fat-saturated, so will be fine. You can use cellular region sequences, and you need to scan the spine, at least on sagittal, to look for vertebral plana. Don't need the whole spine protocol. This will be enough. So we need to confirm, exclude all the specific clinical queries and all the location typical of LCH, taking in account limited time. And this we have very like little inputs from literature that focus on very advanced technique or very striking findings, but how to scan in a simple, effective way may be challenging. Another case of a mastoid lump that was, this is a companion case, was called LCH. Now look at this scan. Again, we have a flare which shows like a fat saturated images. This is all your flare, but the post-contrast was done despite this was a skull-based query with a normal brain. The same for the T2, and the diffusion was a normal diffusion. You can see how artifacted is that. Luckily enough, because they were scared, this was an external scan, because they were scared about the thrombosis of the sinus, they did a CTV. Now, I don't like CTV. I like MP-RAGE pre and post contrast with MRV and diffusion, but this is another protocol. But in this case, you see the difference from the previous one. Where is the lytic aspect? This is a permeative lesion in an infant, so very young also for an LCH possible, but still. And this appearance is very, very different from what we expect in LCH, very lytic changes. When you see a restrictive, aggressive mass with permeative appearances on CT in a very young child, you don't think LCH, you think neuroblastoma first. And this child does not need a biopsy as was initially planned. This needs chemotherapy. So ask for an ultrasound of the abdomen, and don't forget the complementary role of CT that allows you from differential diagnosis. This is another case of neuroblastoma with a very weird location in the orbits, but again, you see these masses, this is more typical, multiple masses, diffusion restriction. What we do next? Ultrasound of the abdomen and MRI. This was neuroblastoma. So we also added a Gauche, we have a specific neuroblastoma protocol where we add fat-saturated post-contrast instead of the standard brain, because like that, we can see better the extension of the metastases that are most likely to involve the skull vault and skull base in cases of medulloblastoma. And again, permeative appearances of the bone. As opposed, not only to the lytic appearance of LCH, but look at the other side of the spectrum. Sometimes you can have some sort of a restriction and you know, query aggressive lesion looking like that, but this on MRI, but looking like that on CT, this is fibrous dysplasia. So remember the complementary role of CT. Another case, retinoblastoma. Again, you will have a lecture later on, but normally they come with the diagnosis of retinoblastoma already because of leukocoria and calcified mass. There is some differential. This is a beautiful paper from Kelly Robson, but normally we know that these patients have retinoblastoma. So why do we scan them? We scan them because they want to know if there is infiltration of the nerve, and so we can use specific sequences for that. If there is calcification, you don't want to irradiate these children, but you can use SWI for it. And if there is involvement of the brain, you can, and the spine actually, you can have trilateral retinoblastoma with pineal involvement, but also brain metastasis and spinal leptomeningeal metastasis. So again, we needed a specific protocol for retinoblastoma, which is different from your orbital protocol, and again, answer the clinical queries. And this, again, the European Retinoblastoma Imaging Collaboration Group helped us in writing this paragraph. Remember the differential diagnosis. You can have Coats disease, Martini glass for PHPV, or retinopathy of prematurity, but normally they don't have calcification. But remember, you can use ultrasound, you can use SWI, don't irradiate this, please, because they are susceptible to radiation. So then the last part of this paper on my presentation, the last 30 seconds, is keep an eye on the future and the broader theme. So we have a lot of advanced technique. We can use nuclear medicine, we can use perfusion technique. Normally the T1 perfusion, not implemented in children. We are trying to implement now ASL. There are some studies, but ASL is a delicate sequence, difficult to standardize and difficult to use in the head and neck region. This is a beautiful paper from Necker in Paris. They showed the difference between high flow and hemangioma and slow flow vascular malformation. You have other elements for differential diagnosis, but this can be helpful. But sometimes it's very, very difficult to do. They did another paper with differentiating rhabdo from hemangioma. Again, very important to use perfusion. But we have a lack of standardization, and we have a lot of differences and a lot of technical challenges. So keep an eye on the advanced techniques, try to implement, but remember, as a starting point, you need to do your basic protocol right, and this needs to be as much disease-specific as possible. So we would like to meet probably every 2 years to try to update this. For now, there's not been many changes. But these are some of the people that were involved, and I'm very thankful for all of them, because as I said, I learned more than I contributed to. So I want to ask you to try to use this protocol, and if we made some mistake, if there was some imprecision, please feedback to us. In general, I think keep an eye on the standardization process. We recently published standardization approach for achondroplasia, for instance. Very difficult to approach as well, but we are trying to do slowly to contribute in that sense. Finally, these are street signs from back home in Naples. They say highway hospital, Naples Salerno, Naples Salerno. Very confusing if you are a medical student first year. I hope I was a bit more clear than that. And if you have some questions, I will be happy to take them. Thank you very much.
Thank you very much, Felice, for your insightful presentation. You really simplified very complex topics, and I think we are. The questions are. I mean, just to remind that you can ask questions in the chat, and me and Dr. Bruchhage, sorry if I don't pronounce correctly.
Oh, that's fine. Yes.
I'm going to take care of the questions. Let's give.
Hi, Felice again. I have a short question, actually. I wanted to ask you showed us the LCH protocol with both brain and vertebra and everything, but or they can be in one order in your institution?
Sorry.
You just order one, we have this one order of MRI, and then you can do all those coverage from brain to spine.
Well, no, they do for spine and brain. I mean, being a public institution is not like the private that if you want extra sequences on the pituitary region, they need to pay or something like that. But yeah, we do 2 orders, like in terms of they request 2 orders. For neuroblastoma, for instance, screening, we have a neuroblastoma protocol. So they request the brain, and the radiographer will do the protocol with fat saturated images, so we could see the metastasis, if any, better. So we give all the protocol to our techs, and they should be able to do them in a standardized fashion, but sometimes they ask us, and it's a learning process, really.
Thank you for the great presentation.
I think Camilo asked if I use 0 echo time. So we don't use at the moment. Some of my colleagues are trying to work with the physicists to implement sequences for the bone. The problem, of course, is amazing, and we should implement that. But at the moment, we have such a low dose CT. I don't know, you probably know Kling Chong. He spent a lot of time in having a CT with so low. Of course, you can use for craniosynostosis and for bone only, not for soft tissue. But at the end of the day, this is very fast, very easy to implement, and cheap. And I think the radio protection problem is very limited for this CT. I have a big problem with CTV, and I don't understand why people do not push for MPRage pre and post-com, because the MPRage or a gradient 3D that is not as good as spin echo for intracranial metastasis, but is excellent for the vessel because the vessels are full of contrast. So you have a CTV-like appearances, and you account for all if you do a flare, DWI, MPRage pre and post, and MRV, you account for all the possible hemoglobin changes, which can be a problem in MRV alone. So that's kind of the approach. I don't like to use CT for soft tissue at all. I saw a lot of also people in US for head and neck using a lot of CT, which I understand maybe in acute setting. But if you can do an MRI, I would always prefer an MRI, unless it's the bone. And for the bone, we just do very low dose CT. I don't know what's your experience, Camilo, because I know that you are very good in the technical side, and if you think you can use that instead of CT.
At this point, I wouldn't say instead, but I also I would say we're starting to use it more and more, and I don't know exactly how far along we're going to get with it as it gets better. So I think the new vendors are coming up with, say, new deep learning things that also increase the sharpness. So I think it is a nice addition. I certainly use it a lot in spine, and say to look for parse defects and things like that. It works beautifully. For head and neck, like it's such an important piece. Like when the bone is destroyed, and it may be so subtle that at this point I'm not ready to let it go. But I'm happy to hear that that your experience is also quite favorable and positive with CT, and I'm still open to seeing what we can build out of that technique.
Yeah.
Thank you.
Yeah. My personal philosophy again, but we are lucky that we are in a tertiary center. But I think I love the MRI for the head and neck problem. And as you say, if you have a tumor, you don't want to take the risk of misinterpreting something. But for instance, for craniosynostosis, maybe good to avoid all this CT and just do an extra sequence.
Felice,
Grazie.
I have questions. I mean, you briefly mentioned about the DWI, and
yeah,
you mentioned that, I mean, it's challenging. And do you use DWI, and what's your experience in separating these solid tumors? I mean, do you use ADC values, or do you rely on ADC for your differential?
So that's something that we are trying to figure out. So we are now acquiring DWI, especially for the orbit. Some of my colleagues are checking all the changes. There are some papers out there. So the problem is that some of the head and neck tumors, including rhabdomyosarcoma, that we know that there should be restriction. Sometimes the DWI is not as restricting as an embryonal tumor, for instance. In the brain, medulloblastoma versus pilocytic, even ependymoma with this mixed thing. I will say that it is probably in these cases perfusion will help. But again, the publication on perfusion, first of all, you need to use T1 perfusion, and then the publication on perfusion for neck hair on differentiating rhabdomyosarcoma from hemangioma, they say rhabdo is more heterogeneous that you can see in normal sequences, but hemangioma is much more like perfused. Actually, it's very, very perfused. So it's a bit tricky. My personal approach is that I use DWI in general as an added value, but I will not bet on DWI as I do for instance, posterior fossa tumor. You need all the sequences. You need to check for the vessels inside, like for instance, if there's an hemangioma, because if you call an hemangioma something that is rhabdo, is a problem. And if you see vessel without a mass and you call an hemangioma and it's an AVM and you let it be, that's a problem as well. So it's really tricky, but yes, I think it's useful, but not as much as in brain, if it answers your question.
Yes, no, thank you. And one last question: do you think MRS will even be tried, or do you see any potential for MRS to separate?
I have no experience, and I think it's very difficult to be used in head and neck. Sorry, I think we are out of time, but
Yes.
I don't have experience, and I think we cannot use it properly. Too much fat. MRS doesn't like fat.
Thank you.
Sorry to interrupt you there, but I think that was a fantastic lecture, a fantastic talk, and I can understand that the comments and questions keep on coming. But I think we should go and continue with the next speaker, if you agree. Do you want me to introduce her, Fabricio, or?
Yes, please.
Okay, all right. I'll keep it a bit short, but that is no. If you have Googled her name, you will know that keeping it short is very difficult. She is more than established figure in the scene. She's a clinical assistant professor at the Department of Radiology at the Catholic University of Korea in Seoul. And her skills and levels of expertise are absolutely bountiful and vary from various applications, from ultrasound, CT, elastography, MR, basically everything under the sun in pediatric neuroimaging. Cutting it a little bit short so that we can also allow for the wonderful talk, I would like to introduce Dr. Hyun Kim, if I pronounce that correctly.
Yes.
And a talk about optimizing orbit MRI protocols for children. Welcome.
Thank you. Thank you for the kind introduction, Muriel. Do you see my slides?
Yes.
You do? Okay. Okay, so my name is Hyun Kim, and I'm an assistant professor in the Catholic University of Korea, and I'm currently working in Incheon St. Mary Hospital located in Seoul, Korea. So as you know, I'm going to start my presentation, optimizing MRI protocol for children, but like most of the part, I think my presentation is going to be echoing what Felice has already talked about orbital MRIs. I have nothing to disclose, and however, since my institution uses Siemens Vita scanner, the sequence names will be according to the vendor's terminology here, but I have no conflict of interest regarding that. I will start with the basic MRI protocol for the orbit and discuss pediatric consideration. Then I will discuss each orbital structure and relevant MRI protocol. And lastly, I will review some brief cases. So let's start with the basic MRI protocol for the orbit. So this is the proposed general orbital MRI protocol for children, which was published by Felice and he introduced in his previous talk. And we need T2, T1 weighted image for axial and coronal images. And for T2 weighted image, fat signal must be suppressed. And additionally, DWI and T1 contrast enhancement sequences should be added to obtain additional information regarding pathology, inflammatory, or infectious lesion. And for two-dimensional image acquisition, the slice thickness should be 3 millimeter or less, but you can consider acquiring T1 or T2 weighted images. For instance, in our institution with 3D sequences, we use those. So you can like substitute maybe some of those 2D images with these 3D sequences. The field of view of orbital MRI focuses on the orbital structure and optic pathway, so make sure the scan covers from the orbital surface to the optic chiasm level on both axial and coronal images. So we're going to go into more detail regarding the sequence and protocols for each orbital structure afterwards. However, before that, we should consider common issues in pediatric orbital protocols. And first thing to consider is the spatial resolution. We have to acquire higher spatial resolution images in children, of course, compared to adults due to their smaller size. And second thing we have to consider is artifact from fat, dental implant, bone, sinus, and motion. And lastly, we have to consider the children with orbital manifestation often comes with intracranial anomalies. So to obtain optimal spatial resolution images, in-plane resolution of 1 millimeter or less, and slice thickness of 3 millimeter or less is recommended for two-dimensional images. And for volumetric images, isotropic focal size of 1 millimeter or less is recommended. And this is, of course, because pediatric orbital structures are often as small as 1 millimeter. To avoid artifacts from intraorbital fat, we can use fat suppression techniques. Fat suppression in orbital MRI is important for reducing chemical shift and misregistration artifact caused by abundant fat in the orbit. And the images on the left are from the old paper published in 1988. However, it showed that chemical artifact was reduced by applying fat suppressed technique. And the image on the right shows the chemical shift artifact appearing as a low signal intensity border on the left side of the globe and optic nerve. So applying Dixon technique for orbital fat suppression is now common, as it can uniformly suppress fat, and at the same time you can acquire other sequences. As you might know, water-only sequence based on Dixon can act as fat suppressed T2 weighted images. So these are the 4 sequences achieved from Dixon on orbit, and again, you can appreciate the fat suppression on the water sequence, right lower side. And susceptibility artifact from sinus or other oral structures can affect orbital MRI images. And here you can see the patient had a dental implant, causing high signal intensity change in the inferior aspect of the orbit on coronal scan. So to reduce motion, minimizing scanning time is crucial, of course. And if your scanner has scan time reduction technique, those should be applied to this orbital scanning. And if the patient is not cooperating well during the scan and moves their eyes, gross artifacts can appear on images, making the globes and optic nerves hard to delineate. And one way to prevent is to provide a focal spot that the patient can actually look at during the scanning. Another option is to apply radio acquisition, and this article published in 2015 compared T1 enhancement images with MP-RAGE and radial 5 sequence, and you can more clearly appreciate the optic nerve and other orbital structure with radial 5 sequence compared to MP-RAGE. And lastly, although it is orbital MRI, we should remember that intracranial abnormalities can manifest with orbital symptoms. So therefore, intracranial vessels, cranial nerves, and optic pathway should be included in the sequences accordingly. So this was also shared by Felice before. However, these are the additional protocols that could be included in the orbital MRI to cover vessel, brain parenchyma, and cranial nerve abnormality. So now let's move on to orbital and intracranial structure evaluation with MRI. And I'm going to go through these major structures in the orbit, including the globe, optic nerve, optic pathway, extraocular muscles, and intracranial nerves. So for globes, we can appreciate the structure with both T1 and T2 weighted images. On T2, the lens will be delineated as a low signal intensity structure inside the hyperintensity globe. The outer part, we call it aqueous humor, and the inner part is vitreous. The iris is at the lateral side of the lens, showing as a low signal intensity thin layer structure. And the globe has 3 different layers, sclera, uvea, and retina from outer to inner side. And on T1 weighted image, the sclera appears as hyposignal intensity, and the choroid retina, which cannot be differentiated on T1 weighted images, will show as hypersignal intensity. So retinoblastoma is the most common intraocular tumor affecting globe in children, and this was also shared by Felice before. But a patient who is suspected to having this retinoblastoma have to be evaluated with a dedicated protocol with higher spatial resolution and additional T1 contrast enhancement sequences with both axial and sagittal oblique along the optic nerve. And the slice thickness is recommended to be 0.6 to 2 millimeter on basic T1 and T2 sequences. And for DWI and FLAIR images, which will be covering the brain, the whole brain, the thickness can be increased up to 4 millimeter. So for the evaluation of optic nerve, fat suppression T2 weighted image is the most useful sequence. As you can see here, the orbital fat is well suppressed on the right side images, and the optic nerve attached to the globe is well delineated on the axial image. On both axial and coronal images, you can evaluate optic nerve diameter and see the CSF space well surrounding the nerve. When scanning axial and coronal images, the plane must be focused on optic nerve, of course. And for axial image, it should be obtained parallel to the intraorbital portion of the optic nerve. And the coronal images should be scanned perpendicular to the optic nerve on sagittal cuts. So a study actually suggested a third fat suppressed sequence for optic nerve evaluation and measure the diameter according to age in children. As with other structures in children, having this normal diameter in mind will increase diagnostic confidence for optic nerve pathology. And axial image, 2 areas were measured in this paper, the first retropulpal and the second mid aspect of the optic nerve. And the normal diameter for each age group were suggested. As you can see, the retropulpal mean diameter starts from 1.35 millimeter in infants, less than 6 months of age, and increased to 2.35 millimeter in children 12 to 18 years old. And the mid aspect optic nerve diameter was smaller than the retropulpal diameter, and each portion of the optic nerve was also measured from the coronal section, and you can see the general increase in the diameter according to age. So since the optic nerve sheath can be differentiated from the optic nerve and is surrounded, the optic nerve itself is surrounded by CSF space, the diameter including optic nerve sheath was also studied in one paper. And the diameter including optic nerve sheath, CSF space, and inside the optic nerve was around 5 millimeter in every age group up to 4 years of age. So for the optic pathway, not only orbital, but intracranial structure should be evaluated. And as you know, optic nerves connect backward to the optic chiasm where the 2 optic nerves meet. And then the optic pathway connects further back to the optic tract, and from the lateral geniculate nucleus of the thalamus, it leads into the optic radiation. So optic chiasm can be appreciated from both axial and coronal images, and since the optic radiation connects back to the occipital lobe, the whole brain covering far back to the occipital lobe is required for the evaluation. So extraocular muscles are best appreciated from coronal images, and you can clearly observe superior rectus, superior oblique, medial rectus, inferior rectus, and lateral rectus muscles on the coronal images on the right. However, inferior oblique muscle cannot be well observed on the coronal section as their course is parallel to the coronal section. Although optic nerve delineation is helped by fast suppressed images, extraocular muscles are well delineated on non-fast suppressed images, as you can see here. So here you see in-phase sequence on Dixon with intraorbital fast signal, actually, with high signal intensity, and internal extraocular muscles. And this is because orbital fat helps delineate extraocular muscles as a background signal. And any fatty change can actually be shown as T1 high signal, high signal intensity on these images can be well appreciated with this non-fat suppressed images. So size of the extraocular muscle matters, actually, but we have to keep in mind that a thicker muscle does not always indicate pathology change. For instance, the lateral rectus muscle here can appear thicker than other muscles due to its oblique course along the coronal plane. The cranial nerves are important in orbital MRI as they innervate extraocular muscles. And as you can see, the third cranial nerve innervates 4 different muscles, the superior rectus, medial rectus, inferior rectus, and inferior oblique muscles. And the fourth cranial nerve innervates to the superior oblique, 6th cranial nerve innervates to the lateral rectus muscle. So in our institution, strabismus is often the reason for evaluating cranial nerves with orbital scans, and strabismus is a visual disorder characterized by the misalignment of the eyes, and the primary cause is disruption in the balance of these extraocular muscle function. And there are like 4 types of strabismus. I'm not going to go over each type here, but I want to remind you that cranial nerve evaluation is important for these patients. So high spatial resolution is especially important for cranial nerve evaluation, and isovoxel 3D heavily T2-weighted image is recommended. This table shows a protocol for forced cranial evaluation scans in our institution with an in-play resolution of 0.6 by 0.6. If we look at the cranial nerve, you can see that the third cranial nerve originates from the most cranial part of the midbrain among the 3 nerves, and from the oculomotor nerve nucleus, the nerve goes out to the ventral part of the brain. With the T2 space sequence here on axial view, you can clearly see the third cranial nerve stretching out from the midbrain, And this third cranial nerve is actually the thickest among the three cranial nerves, but as you can see from the images of a young patient below, the younger patient below, the nerve can be thinner depending on the patient's age. The first cranial nerve is unique in its course, and like other nerves, it crosses to the dorsal side of the midbrain and crosses to the opposite side of the original nucleus. And on these 3D T2 weighted images, you can appreciate the thin trochlear nerve coming out of the midbrain. Since the cisterna course curves downward and since it is the thinnest nerve, sometimes the fourth cranial nerve cannot be well delineated even with the high resolution, high spatial resolution T2 weighted images. So here, multiplanar reformation of the image can help. Both images on the right show the fourth cranial nerve in the same patient. In the upper image, the left fourth cranial nerve is not well delineated along with the distal course of the cisterna part. However, when we reformatted the image using multiplanar reconstruction, the left side fourth cranial nerve is now well visible. The sixth cranial nerve originates from the dorsal side of the pons, and it has the shortest track to the cavernous sinus. On the axial T2 image, you can see the right sixth cranial nerve coming out from the pons and going directly to the cavernous sinus, ending by innervating the lateral rectus muscle. And along with other cranial nerves, the sixth cranial nerve requires high resolution T2 weighted images for cisternal portion evaluation. And this study actually compared these two sequences, and you can see 3D CISS sequence does show sixth cranial nerve more clearly than the T2 FSC sequence. In the cavernous sinus, third, fourth cranial nerves are at the superior lateral side of the intercranial artery, and the sixth cranial nerve is at the inferior side of the artery. And the images here were from two-dimensional Dixon and reformatted images from T1 3D sequences. And clear identification is hard for each cranial nerve here. However, if there is pathologic lesion, like thrombus in the cavernous sinus, you can expect the cranial nerve inside would affect those cranial nerves going inside the sinus. So now we're going to briefly go over some of the cases. I will not go into detailed diagnosis or pathologic review for each cases, but it's going to be a really short review on each cases. This was a 17-month-old girl with a strabismus and right superior oblique muscle palsy was suspected. And you may notice that the right superior oblique muscle is not well visible on coronal section, unlike the left superior oblique muscle. On the fourth cranial nerve scan, the right fourth cranial nerve was not visible, so trochlear nerve absence was suspected. This was a 14-year-old girl with right optic nerve atrophy on ophthalmologic evaluation, and on Dixon water sequence with fast suppression, the right optic nerve was asymmetrically smaller compared to the left side, and the diameter was actually small for the patient's age. This is a 2-year-old boy with leukorrhea, and as you know, this was like retinoblastoma, and you can clearly see the mass on T2 weighted images. And after chemotherapy, the shrunken and dysmorphic right globe was shown, and the retinoblastoma mass itself was shrunken. This is a 5-year-old showing vitreous protrusion to the posterior side of the T2 weighted images. And the finding was consistent with coloboma, and there was associated optic chiasm abnormality and ipsilateral cranial artery hypoplasia. And this was a patient who had periventricular glaucoma lesion, and you can see the whole brain covering T2 flare images with dilated lateral ventricles and some periventricular white matter signal changes. And the patient showed bilateral optic nerve atrophy and thinning of the optic chiasm. So in summary, review the basic MRI protocol for the orbit and pediatric optimization of the protocol, and optimal spatial resolution is required for children, and artifacts from fat, bone, sinuses, and motion should be avoided. Since intracranial abnormalities can be present, the scan should cover those structures, and additionally review basic anatomy and their MRI images of the globe, optic nerve, optic pathway, extraocular muscles, and cranial nerve structures. And retinoblastoma again requires dedicated protocol. We also discussed the normal value of optic nerve diameter for children according to age and the usefulness of multiplanar reformation for cranial nerve evaluation. Thank you for your attention, and I'll be happy to take questions.
Thank you for an amazing talk. I'll just want to remind everyone that the recordings are being uploaded as well to both the WFPI and ISMRM websites. But please, we are both looking at the chat, so please keep them coming if you have any questions. Yeah.
I have a question, actually 2 questions, simple questions. Thank you very much, Dr. Kim, for the beautiful presentation, beautiful slides. And do you ever use surface coils to study the orbits? And the other question is, and if you use it, do you see any utility of it? And another question is, I follow around 3-4 patients with tiny lesions in the oculomotor nerves, different sides, and they show minute size, enhancement, and it's always a debate between schwannoma, hemangioma. Do you have a way to differentiate those lesions?
Okay, so the first question was like whether I am using surface coil for orbital MRI. So the answer is no. We don't actually have that surface coil for the pediatric patients here. So instead, we just use 64-channel head coil for the scanning. But however, as you might know, it might reduce other artifacts coming from, airs and all. So it might be a good choice to have a surface coil dedicated for orbital MRIs. And for the second question, I don't think I have the answer for that. I'm sorry. Yeah, I think it's really tricky to differentiate the two. Maybe like perfusion might help, as Felice discussed earlier. However, I don't have the answer for that. I'm sorry. Yeah.
I'm quite aware of time, although I'm quite sure there's a lot of questions that are coming your way or your orbit, if you may. Well, I actually had some questions. I can maybe with going already over time, might email you later. But I thought both of these, and I'm quite sure that everybody agrees, these were absolutely excellent talks, and what a great opportunity to combine the WFPI and the ISMRM in giving these lectures and making them available for everyone for review as well. I think it would be also great to advise the audience that the next webinar is being held on July 18th. I'm sorry, I took some notes. I think I have to register for that as well. With the theme of MRI protocols for liver and bowel. So we're going downwards, and to watch out for the program announcements. But I think everybody agrees that this was an absolutely fantastic event. Thank you so much to the organizers. Thank you for asking me. And most of all, thank you so much for the speakers.
Thank you.
Thank you very much.